request everyone if we can open our camera for photo documentation purposes. So to our participants, again, may I request everyone if we can mute po yung microphone po natin while the session is ongoing. And of course, if you have questions regarding the topics na pag-uusapan po natin ngayong umaga, you have the opportunity to raise your questions maya-maya lamang po during the open forum portion of our activity, and you can also message it here dito po sa ating chat box. And of course, para mabigyan po namin kayo ng inyong certificate of participation, we will be sending the evaluation link na ipapasagot po namin sa inyo individually maya-maya lamang para makuha po ninyo yung inyong mga certificate of participation for today's activity. And of course, allow me to acknowledge our participants for today's activity, no? So, nakita-kita po muli tayo, magkakasama po ulit tayo kahapon, but allow me to acknowledge pa rin po yung ating mga participants for today's usapang Salun-at. Of course, the never-ending or unending support from our different district jails po ng BJMP po. No? We have the Tabuk District Jail, female dorm. We have from BJM Picar. We have from Baguio City Jail, female dorm. We have La Trinidad District Jail, Municipal Jail, both male and female dorm. Of course, we have from Paracelis pa po, Municipal Health Office. From Scout Barrio, Barangay and Lower Aquarian. Yung iba po na hindi ko pa po na-mention, good morning po sa ating lahat. Ito po, meron pa po tayo from MRR, Queen of Peace. So, we are 54 in our virtual platform, virtual floor, but if you can see, we are joined by groups po. So, hindi lamang po 54 yung kasama po natin ngayong usapan po na ito. So, without further ado, no, before we'll be listening to the opening remarks and before he will introduce to us our resource speaker, allow me to invite everyone po, no, this month. Our regular session is on August 16. So August 16, that's the third Wednesday of the month. That's our 8th session for our Usapang Salun-at 2023. Ang pag-uusapan po natin ay patungkol naman po sa asthma at patungkol po sa kung paano pangalagaan ang ating mga mata. So in celebration of the Sight Saving Month, that is on August 16, 9 to 12 noon via Cisco WebEx. So the link for registration ay nakapost na po dito sa ating chat box. So pwede na po kayong mag-register. It's for free. Again, that's on August 16. Pag-uusapan po natin ang patungkol sa asthma at kung paano po pangalagaan ang ating mga mata in celebration of Sight Saving Month. And before that, allow me to give a short background muna regarding the activity for today. So about 15 people are diagnosed with sarcoma daily, but 75% are unaware of what it is. For the past 15 years, July has been dedicated to sarcoma awareness as part of Global Health Initiative. This month, the month of July, emphasizes the value of educating the local population about current findings, early diagnosis, and their effects on the families of those impacted. In celebration of the Sarcoma and Bone Cancer Awareness Month, our Public Health Unit is conducting po itong Usapang Salun-at sa Komunidad Special Edition with the theme, Sarcoma for Your Information, a Multidisciplinary Theme, Awareness. So our activity for today aims to increase awareness on sarcoma and bone cancer among community members through proper dissemination of information. And after this activity, we will understand the importance of sarcoma and bone cancer prevention and management, and of course, to be fully aware on the early diagnosis and impact of sarcoma and bone cancer to families and communities, and for us to be able to apply our learnings from this webinar to our respective community. So to formally start, and to introduce our resource speaker, may we listen also to his opening remarks, one of the medical specialists of our Department of Orthopedics. Let us welcome Dr. Isagani Garin. Good morning po, Doc.
Hi. Good morning to everyone. At kami ay nagagalak at marami tayong mga participants coming from all uh, communities here in Baguio, not only around Baguio but Car region. Nandiyan ang DJMP, Paraceles, etc. We are very honored to have you with us. It's been a wait. It's been we waited for so long for this to be presented and to impart the essential information regarding sarcomas. So first off, I am Dr. Garin. I specialize in orthopedic oncology. Uh, my main practice is doing tumor surgery, most especially soft tissue sarcomas and bone sarcomas. Ito po yung mga cancers sa kamay, sa paa, uh, na sa mga bata at sa mga matatanda. Now, uh, we are very honored. The team has prepared a 4 different talks, and the order of presentation uh, shall be one by Dr. Kyle Paulo Idoba, uh, a medical officer of the orthopedic department. He's a third year uh, trainee, followed by the Dr. Dr. Kim Daniel Fianza, a medical officer of our own pediatric oncology, under the supervision of Dr. Sabrina Florendo, pediatric oncologist, and then followed by Dr. Cinderella M. Herna Tirao, a medical officer from the medical oncology department. Okay, and last but not the least, our very own, and we are honored to have with us our sole radiation oncologist, Dr. Armel Klein Baldonado. Okay, so without further ado, again, maraming salamat po. Hopefully, we can pick up a little thing or a little one or uh, important necessary information from this webinar. And again, maraming salamat also sa Public Health Unit and BGH MC. Thank you and good luck.
Thank you, Doc. Isagani Garin, our medical specialist 4 of the Department of Orthopedics. So to start with, so like what Dr. Garin mentioned po kanina, we will start the discussion with Dr. Kyle Paulo Idoba, one of the medical officer of the Department of Orthopedics. Dr. Kyle, good morning.
Good morning po. I'll set up lang po my presentation. Can you see my screen po, doctors?
Yes, Doc. You may proceed po.
So, hi. Do you uh so so how do you ano po parang so good morning. Ay, so good morning everyone. I'm Dr. Cal Paulo Idova, third year resident from the Orthopedic Department of Baguio General Hospital Medical Center, here to present to you a discussion entitled School Buccal Commonly Encountered Bone Tumors in Our Community. So to start up, here is a pie graph of our uh, cases from 2018 to 2022, showing you that majority of the cases involves the UBC or osteosarcoma, which is a malignant tumor involving different parts of the bone. And another would be metastasis, which comprises 33% of these cases. So, so yes. Mhm. So, sorry, sir, I'm having problem with that. Sorry, sir, ay inayos ko lang po. Nag-auto-play kasi.
Sige
So,
lang daw, you may take your time.
so next, the general principles. So an adequate history and physical examination are the first and most important steps in evaluating a patient with a musculoskeletal tumor. History alone can guide us on the probable differentials of bone tumors. They most commonly seek consult complaining of pain, which may either be actively related or in some malignant cases, progressive pain at rest, and in some cases may present with an enlarging mass. History of a fast-growing mass would make us think more of a malignant or aggressive tumor. Complete and thorough physical examination, not only on the site of complaint, as previously shown, one of the most common bone tumors are metastatic in nature, meaning that they have spread from a primary bone tumor or from a primary tumor elsewhere. This would involve the cases such as lung cancer, breast cancer in females, prostate cancer, thyroid and renal or kidney cancer, which should be examined and investigated with a complete workup. The physical examination should include evaluation of the patient's general health and a careful examination of the part in question. The area should be inspected for visible swelling, varicosities, deformities, and overlying skin changes. Palpation assesses tenderness, presence of mass, and the characteristic of the mass, as well as the neurovascular status of the affected extremities such as perfusion, sensory deficits, and motor weakness. Presence of lymphadenopathies or kulane within the area of lesion should be investigated. All suspected musculoskeletal neoplasms or tumors should be evaluated initially with plain radiographs or X-ray, which is the most important diagnostic tool and luckily readily available in most healthcare institutions. Often, the patient's age and plain radiograph findings are sufficient to arrive at a specific diagnosis of a type of bone tumor. Radiographic evaluation should begin by determining the site of the lesion as well as the characteristic of the lesion, whether lytic or blastic in appearance, because many bone tumors have a specific site predilections and certain appearance. Here is a sample radiograph showing the typical appearance of certain bone tumors and its site predilection. So I would not go through it one by one, but just to show you the example. So next we have a CT scan is a high-resolution imaging that is most helpful in assessing ossification and calcification and in evaluating integrity of the cortex. Reconstructions in the sagittal and coronal planes provide useful information with regard to surgical planning. CT scan of the lungs also is the most effective study to detect pulmonary metastases. Bone scans are used to determine the activity of lesion and to determine presence of multiple lesions or skeletal metastases. So this study would search for other possible tumors that is asymptomatic or meaning has no does not present any symptoms in the patient. MRI is the study of choice to determine the size, extent, and anatomical relationship of the bone and soft tissue tumors. It is the most accurate technique in determining the extent of intramedullary and extraosseous disease and the relationships to neurovascular status. Ultrasonography is useful in distinguishing cystic from solid soft tissue lesions, but otherwise offers little information due to its poor bone penetration. A basic metabolic panel may be indicated to evaluate the overall health of a patient. CBC to rule out infection and leukemia, ESR, CRP, serum lactate, LDH, calcium, ALP, etc. are also determined. An important principle is that the definitive treatment relies on a biopsy that is accurate and does not cause harm to a patient due to technical mistakes. A poorly planned and executed biopsy may result in contamination surrounding healthy tissues, which may increase the risk of local recurrence and preclude the option of a limb-sparing surgery. Presented here are the biopsy principles that should be followed. So first, we have to do a longitudinal incision in the extremity. Biopsy site should be a long planned incision, line of definitive treatment, and be removed and blocked with a tumor. The vascular bundle should not be dissected. It should be dissected within a single muscle compartment only. Meticulous hemostasis. If a drain is used, it should exit in line with the incision and be incised and blocked with a tumor. The wound should be closed tightly, and that wider tension suture should not be used. Here is showing you the different. So it has advantages and certain disadvantages. The general principle is that the bigger sample size is better for histopathologic studies, but it's a concomitant increase in possible surgical complications. So I will not go through it one by one. Next, we have the the primary goal of treatment in a patient with a primary malignancy of the musculoskeletal system is to make the patient disease-free. The goal of treatment of a patient with metastatic carcinoma to bone is minimize pain and preserve the function of the affected extremity. The optimal treatment of the tumor often requires a combination of radiation therapy, chemotherapy, and surgery. So first, we have GCT or giant cell tumor. So according to a Mayo Clinic series, giant cell tumors represent 5% of the bone. They typically occur in patients 20 to 40 years old, and there is a slight female predominance. The most common location for these tumors is the distal femur, followed closely by the proximal tibia. And so the bones involving the knee. Then we have the distal radius, and wherein tumors in this area frequently are more aggressive. Although these tumors typically are benign, pulmonary metastases occur in approximately 3% of the patients. The overall mortality rate from disease for patients with pulmonary metastases is approximately 15%. Most patients with giant cell tumors have progressive pain that often is related to activity initially and only later becomes evident at rest. The pain is rarely severe unless a pathologic fracture has occurred. Pathologic fracture occurs at 10 to 30% of the patients. This is due to the weakening of the bone due to the tumor and are evident at initial examination. X-ray findings often are diagnostic, and the lesions are eccentrically located at epiphysis of the long bones and usually above the subquadral bone. Radiographically, the lesions are purely lytic or appear translucent in X-rays. Microscopically, giant cell tumors are composed of many multinucleated giant cells, typically 40 to 60 nuclei per cell in a sea of mononuclear stromal cells. So to show you a sample case in our institution, here is a gross image of the knee of a 22-year-old female with a giant cell tumor. So as you can see on the X-rays of the patient on AP or front view and lateral or side view of the knee, you can appreciate a lytic lesion. So comparing it to the normal bone, which is very white in X-ray, there is a dark area or dark spot here on around the knee area. So next we have osteochondroma, which is are common benign tumors. They are probably developmental malformations rather than true neoplasms, and are thought to originate within the periosteum as small cartilaginous nodules. The lesions consist of a bony mass, often in the form of a stalk, produced by progressive endochondral ossification of a growing cartilaginous cap. In contrast to true neoplasms, their growth usually parallels that of the patient and usually stops when skeletal maturity is reached. Osteochondromas may occur on any bone preformed in cartilage, but usually are found under the metaphysis of the long bone near the physis. They are seen most often on the distal femur, the proximal tibia, and the proximal humerus. So many of these lesions cause no symptoms and are discovered incidentally on X-rays. Plain radiographs usually are sufficient to make a diagnosis, and surgery or en bloc or the resection of the whole segment is indicated only when the lesion is large enough to be unsightly or produce symptoms from pressure and surrounding structures. So to show you another case in our institution, here is a gross image of an 11-year-old male presenting with a mass on the posterior or the backside of his leg. So upon X-ray, we can appreciate multiple lesions. So much of this will not be treated surgically because, as previously mentioned, they are usually asymptomatic or has no symptoms. But due to the large lesion or large bone mass on the posterior aspect or the backside of the leg, we had to remove it since the patient is already presenting with pain. So next, we have unicameral bone cyst or UBC. These are common lesions of childhood and more consistent with a developmental or reactive lesion than a true tumor. 85% occur in the first 2 decades or with a 2:1 male predominance. Any bone of the extremities can be affected, but unicameral bone cysts are most common in the proximal humerus and femur. In adults, the ilium or the bone in our hip and calcaneus or the bone in our foot are more common locations. The lesions are most active during skeletal growth and usually heal spontaneously at maturity. Unicameral meaning one-chambered, so it would appear as a single lytic lesion on the bone. Unicameral bone cysts often are asymptomatic, so showing no symptoms unless a pathologic fracture has occurred. So pathologic fracture, meaning that there is a weakening of the bone due to the tumor causing a fracture. So 2/3 of the patients present with fractures which can stimulate the cyst to heal. X-rays reveal a centrally located, purely lytic lesion with a well-marginated outline and usually are diagnostic for a unicameral bone cyst. The cyst may expand concentrically but never penetrates the cortex, and small asymptomatic lesions in the upper extremities can be treated with observation with serial plain radiographs. So not all lesions or tumors will need treatment or surgical intervention. Larger lesions at risk for pathological fracture, symptomatic lesions, and lesions in the lower extremity usually are treated with surgery. So here is a sample case again in our institution, showing you the X-ray of a 12-year-old male with a UBC or unicameral bone cyst of the right ilium. So the ilium is on your screen is on the left. So you can see the large lesion on the left ilium, which can be seen compared to the normal bone is less white or darker in color. Next, we have aneurysmal bone cyst, so or ABC. These are locally destructive blood-filled reactive lesions of bone and are not considered to be true neoplasms. Any bone may be involved, but the most common locations include the proximal humerus, the distal femur, the proximal tibia, and the spine. So vertebral lesions accounting for 15% to 20% of these entities are located in the posterior elements. Most occur in patients younger than 20 years old, and there is a slight female predominance. Most patients with aneurysmal bone cysts complain of mild to moderate pain that has been present for weeks to several months. X-rays reveal an expansor lytic lesion that elevates the periosteum but remains contained with a thin shell of cortical bone. An aneurysmal bone cyst can have well-defined margins or a primitive appearance that mimics a malignancy. It is most often eccentrically located in the metaphysis. Showing you again a sample case in our institution, ABC or aneurysmal bone cyst of a distal radius. So this is one of the bones of the wrist. So you can see the lytic lesion or the dark lesion on the distal portion of the radius. And on MRI, which is the image on the right, showing you the lesion, wherein the lesion has multiple divisions or septations. So this is very characteristic of aneurysmal bone cyst. Next, we have osteosarcoma, which is a tumor characterized with production of osteoid by malignant cells. So comparing to the first tumors that I have discussed, this is one of the malignant tumors. Malignant meaning it is cancerous, so as layman term. It is the most common non-hematologic primary malignancy of the bone, accounting for approximately 20% of these malignancies. So I have shown you the pie graph on the first slides of my presentation that osteosarcoma has a high predominance in our institution. So onset can occur at any age. However, primary high-grade osteosarcoma occurs most commonly in the second decade of life. Almost all patients with high-grade osteosarcoma report progressive pain. Patients with low-grade surface osteosarcoma may report a painless mass that results from the microinfarctions as the invasive tumor cell weakens the involved bone. Pain initially may improve with conservative measures and activity modifications, which can lead to a false sense of security for the patient and the physician. The pain eventually becomes severe if the diagnosis is delayed. Night pain may be an important clue to the true diagnosis. So plain or X-rays are the most valuable tool for making the correct diagnosis. The most common appearance is that of an aggressive lesion in the metaphysis of the long bone. Although the lesion can be either predominantly blastic or predominantly lytic, more commonly areas of bone production and bone destruction are present. The lesion usually is quite primitive and the borders are ill-defined. If the tumor has broken through the cortex, a soft tissue mass may be present at the time of diagnosis. Periosteal reaction may take the form of a Codman triangle or it may have a sunburst or hair on an appearance. MRI is the best measure to test imaging to measure the extent of the tumor within the bone and in the soft tissue and to determine the relationship of the tumor to nearby anatomical structures. A bone scan should be obtained to look for skeletal metastases, and radiography and CT scan of the chest should be done to search for pulmonary metastases. The lungs are the most common sites of metastases. So, uh, showing you a sample case again in our institution of a 24-year-old male with a mass on the left side on his left knee, sorry. And on the radiographs, we can see the very aggressive nature of the lesion or the tumor. Next, we have multiple myeloma. So, multiple myeloma is the most common primary malignancy of the bone, representing more than 40% of the primary bone cancers. Its peak incidence is in the 5th to 7th decades, with a 2:1 male predominance. Bone pain is the most common complaint for patients with multiple myeloma or with a solitary plasmacytoma. In contrast to most bone tumors, however, other systemic problems such as weakness, weight loss, anemia, thrombocytopenia, peripheral neuropathy, hypercalcemia, or renal failure frequently are present at the time of diagnosis of multiple myeloma. Symptoms usually are of short duration because of the aggressive nature of the tumor, and pathological fractures are relatively common. The spine is the most common location, followed by the ribs and the pelvis. Radiographically, multiple myeloma appears as multiple punched-out lesion, sharply demarcated, purely lytic lesions without any surrounding reactive sclerosis. Here is a sample case again in our institution of a 47-year-old male with multiple myeloma. Here is an X-ray on front view or AP and side view or lateral view of the femur or the bone in our thigh, showing you the multiple lesions or multiple lesions of the affected bone. Next, we have metastases or tumors that have spread from another tumor. So it is the most common malignancy treated by orthopedic surgeons. If a patient has a known history of a carcinoma, even in the remote past, a newly discovered bone lesion is most likely to be a metastasis. In any patient older than age 40, even without a history of malignancy or cancer, a newly discovered aggressive appearing bone lesion is most likely to be a metastatic carcinoma or multiple myeloma. Briefly, the workup consists of history and physical examination, including breast and the prostate. Basic laboratory tests, including serum protein, electrophoresis, and possibly prostate-specific antigen. A radiograph of the entire involved bone, a chest radiograph, a bone scan to look for other signs of disease, and a CT of the chest, abdomen, pelvis. Failure to complete this workup before biopsy can lead to serious errors in patient care. So most of the time, we complete all this imaging or workup prior to doing anything or biopsy or surgery. So it is very important for this workup to be complete. So sometimes patients are very hesitant or wants to do surgery immediately, but this is one of the important things that they should understand. After the workup is complete, a biopsy can be performed. Even if a patient has a known history of carcinoma, a biopsy of the first site of bone disease must be performed to establish a firm relationship between the primary carcinoma and the suspected metastasis. So as previously mentioned, these are the some of the most common sites for the primary malignancy or cancer. So breast cancer, prostate cancer, lung, kidney, thyroid, and colon cancer may metastasize or spread through the bone. So here is a sample case of our patient, a 70-year-old female with a pathologic fracture of the left femur, which is secondary to a metastatic tumor. So due to the tumor, it weakened the bone on her left, which is on the right side of your screen, causing fracture. So for my last slide, the take-home message is that thorough history and physical examination is very crucial in diagnosing not only bone cancer or bone tumors, but majority of tumors. Careful review of the imaging, as previously mentioned, the crucial or very important X-ray, which is a very basic imaging and is mostly available in our healthcare institutions. Referral to a tertiary hospital or specialist should be done because these are very special cases and should uh, and in need specialized care. So the goal for surgery or management is be tumor-free, reduce the recurrence, minimize pain, maintain the function of the extremity, and maintain independence and improve the quality of life of the patient. So thank you.
So, ayun po, no? So, thank you, Dr. Kyle Paulo Idoba, one of our medical officer of the Department of Orthopedics. So, sa ating mga audience po, no? Ang dami pong klase po ng bukol, okay? So, gaya po ng mga ni-lecture po sa atin ni Dr. Kyle Idoba. And yun nga po, kung may mga bukol, kung may mga tumor, kailangan pong i-refer po siya doon sa mas mataas na level po ng health facility, no? Katulad po ng BGHMC, at kailangan makita po kayo ng isang specialista dahil ang goal naman po ay maging bukol free at to minimize pain. So maraming salamat po, Dr. Kyle Paulo Idoba. So let's proceed with the next topic to be given by one of our medical officer of the Department of Pediatrics, Dr. Kim Daniel Fianza. Good morning po, Doktora.
Morning, sir. Good morning, everyone. Is my screen shared po, sir?
Yes po, Doktora.
Okay. Good morning, everyone. I'm Kim Daniel Fianza under the Department of Pediatrics. With me, I have Dr. Sabrina Villanueva under Hema Onco. So we would like to share a few slides and points regarding sarcoma bone tumors. So, ang pag-uusapan natin ngayong araw, yung mga common osteosarcoma, Ewing, and rhabdomyosarcoma. So, gaya na ng sinabi kanina, the assessment of bone lesions is based on age, pain, trauma, the duration of symptoms, swelling, and other symptoms, fever, fatigue, chills, kung ano pa man nararamdaman. The most common that would be felt is pain, limping, and swelling. Pain is usually felt as deep bone pain, causing children, yung mga bata, they would wake up at night complaining of the pain. And then, kapag dumating sila sa amin, when we examine them, we check for the tenderness, the swelling, other masses in the other parts of the body, deformity, and the range of motion. Tapos, and then we do imaging, pinapa-x-ray namin, CT scan, so that we would know the location, the border, kung ilan ang bukol doon, if there is destruction to the bone, the involvement ng muscles or other things are surrounding the bone, we do the imaging. So, the first primary malignant bone tumor that we have would be osteosarcoma. So, but primary malignant bone tumors is the 6th most common malignant neoplasm in children. Most common types would be osteosarcoma and Ewing sarcoma. But the most common would be osteosarcoma, seen by this green pie over here, and then the next would be Ewing sarcoma. So osteosarcoma, most common primary bone tumor. 3% of all cancers in children would be osteosarcoma. In high-income countries, first world countries, United States, Europe, 3.9 cases per 1 million population. However, there is lack of data in our countries, low to middle income countries. but in the UP Philippine General Hospital, it is the fifth most common solid tumor, and from 2013 to 2016, there were 102 new patients. So madami-dami na to. In pediatrics, the peak incidence is during the second decade of life. So in females, it's 13 years old. In males, 15 to 17 years old. Bakit? Why? Because there is skeletal growth velocity. This is when the bone grows. So it is more frequent in males than females. Mas daming makikitang osteosarc sa mga lalaki kaysa sa mga babae. So here on this chart, we could see that at the age of 15 to 19, there are more males and there are more females. So again, pain is the most presenting symptom. Trauma, kung nabaling buto, usually hindi siya etiologic factor. It is a rare exception in pathologic fracture. The second most common na makikita natin is swelling around the affected bone. There is a soft tissue mass and there is limping. Rare ang makikita. It's not common to see fever or other constitutional symptoms unless advanced na sila, kumalat na. So here, like this patient, on physical exam, we can see a tender soft tissue mass. There is decreased range of motion, di na makalakad, makagalaw ang kamay. In lower to mid-income countries, there is a high tumor burden. Ibig sabihin, hinintay na lumaki, and there is a higher frequency of metastatic disease, hinintay na kumalat. Once we get these patients, we request LDH, where we see an elevation, and alkaline phosphatase, which is increased or mataas sa advanced disease. So osteosarcoma arises spontaneously in areas of bone without any abnormality. 80% of lesions are found in extremities, and there is predilection for rapidly growing bones. So the distal femur, the proximal tibia and humerus, and the axial skeleton, including the pelvis, this one is rarely affected. It is most commonly seen in the metaphysis, this part which is between the diaphysis and the epiphysis. So if we get x-rays, ang usual na nakikita natin, sunburst pattern or Codman's triangle. So usually itong first na pinapagawa kapag may bukol, pinapadala sa amin dito sa Baguio General Hospital, first to do x-ray, and then we see these things. Kung anong makikita namin, we would request for CT or MRI. To evaluate to spread, we ask for bone scan so that we can stage. Tapos biopsy, of course, napaka-importante. So poor prognostic factors. So if there is presence of metastatic disease or kalat, there is presence of skip lesions and pathologic fractures. Those are poor prognostic factors. Treatment combination, hindi lang po chemo ang ginagawa, surgery alone, surgery also is done, and then radiation has no role in upfront treatment of osteosarcoma. However, overall survival, if there is spread, is less than 20%. In high-income countries, 70 to 80% survival. Here in low to mid-income countries, 50% survival rate. We move on to the second most common, Ewing sarcoma. It is a small round cell neoplasm of neuroectodermal origin that arise in children and young adults. So 3% of pediatric malignancies are Ewing sarcoma. So there are 2.8 cases per 1 million population in less than 15%. And again, second decade of life po sila nakikita, adolescent. Peak incidence of 10 to 15 years, the median age of 13 years. 30% in less than 10 and more than 20 years old. So kabataan po nakikita. Again, males more than females, in white people more than black and Asian people. So in Ewing's, there is equal distribution between eggshell and extremity. Again, most common sites are the long bones, the pelvic, the chest walls, and the ribs. Kung sa osteosarcoma, usually on the long bones, pwede sa Ewing's, the pelvic, the chest, and the chest wall or ribs. Same pa din. They come in with localized pain, a mass. Usual time of diagnosis is 3 to 9 months. Ewing's naman, mas nakikita ang fever, weight loss, and malaise in around 15 to 20%. There is back pain, extremity weakness, or altered sensation. It usually shows primary or metastatic disease. It depends. So, in X-ray or in laboratory, kapag pinapagawa natin, there is elevated WBC and an increase in ESR. Ito po yung rine-request namin, LDH. X-ray shows an onion peel. And the next that we would request would be the CT and then the MRI. Of course, most special importance is the biopsy. So, staging is important to evaluate the extent and the presence and sites of spread. So, dapat ma-evaluate, makita lahat kapag may kalat. So, hindi lang yung bukol ang kailangan i-X-ray or i-CT scan or i-image. Pinapa-CT scan ang iba't ibang parte ng katawan para hanapin or tignan kung may kalat. So, metastatic status at diagnosis is the strongest prognostic factor. Tumor volume, so yung gaano kalaki ang bukol, the presence of bone lesions and bone marrow involvement, importante po ito para makita kung gaano kaganda ang Ewing sarcoma sa isang pasyente. Again, it is a multidisciplinary approach with both surgery, with the orthopedics department, radiotherapy if needed, along with the chemo. The overall survival in high income uli, kapag localized, 70%. Kapag metastatic, kapag may kalat, 20 to 25%. Limited ang data natin sa low-income countries, pero sa PGH, 31% ang survival. So ito ang madali ang table na makikita ng difference between osteosarc and Ewing's. Again, second decade of life, mga kabataan, most common. For rhabdomyosarcoma, it is the most common pediatric soft tissue sarcoma, most common in ages 1 to 4 years old, and then here 5 to 9, 25%, 22% in ages 10 to 14 years old. Here, most common 23% in the genitourinary, and then here 20% in the extremities. So the most common presenting feature is a mass that may or may not be painful. Pwedeng masakit, pwedeng hindi. Symptoms are caused by the displacement or obstruction of normal structures. So first noticed after trauma and then initially recorded as hematoma. But if the swelling does not resolve or the swelling increases, isipin na bukol. So rhabdomyosarcoma requires a high index of suspicion for diagnosis. Imaging again, CT scan, bone scan to stage it, and then BMA or bone marrow aspiration. So rhabdomyosarcoma has an overall survival rate of about 71% with combined modality therapy, which is chemo, radiation, and surgery. It is determined by the clinical group, the stage, the histology, the age of presentation. So for low risk, minimal therapy, chemotherapy, vincristine, actinomycin, radiotherapy after surgery. Intermediate risk, other drugs, addition of other drugs, cyclophosphamide, irinotecan, along with the radiation. And for high risk, intensive multi-agent chemotherapy. So in summary, kapag may nakitang bukol that does not go away, send the patient, immediately think of, aside from chest, you can do your x-ray and then you can send the patient to us. Pain is the initial manifestation. There is also a mass. So kapag may iba't ibang simptomas, fever, nawalan ng timbang, mas iisipin, Ewing's. Treatment is by many departments, hindi lang chemo, pwedeng radio din, and pwedeng, and also surgery. Early detection means better survival. That's it. Thank you.
Maraming salamat po, Dr. Kim Daniel Fianza, our Medical Officer 3 of the Department of Pediatrics for your presentation. So, kung titignan po natin, no, magkakaiba po yung konteksto pag pinag-uusapan po natin yung sarcoma at bone cancer. So, iba po sa konteksto ng pediatrics. Iba rin po yung diniscuss kanina ni Dr. Idoba. Pero ang pinaka-end naman po nito, kung may bukol, kailangan pong magpatingin sa specialista. And before we proceed with the third topic po, no, may I request everyone if we can open po yung camera po natin para tignan po natin, no, kung andito pa rin po tayo at patuloy po tayong nakikinig sa ating mga resource speakers. And while waiting for everyone to open their camera, allow me to acknowledge po na yung mga hindi ko po na-acknowledge po kanina. So meron po tayong kasamahan mula po from Bugyas District Jail. Also from San Roque Barangay. We have also from Aurora Hill. So ayan, so good morning po sa ating lahat, and of course yung ating mga kasamahan sa community, no, mga barangay health workers, barangay nutrition scholars, barangay officials. Good morning po sa inyong lahat at sana po ay ligtas po tayo ngayong umaga kahit medyo maulan-ulan pa. Okay, so kung, ayan, meron pa po tayo from Atok Trail Barangay. Good morning po, Ma'am Mary Jane. So sa ating mga participants, kung meron po kayong mga karamdaman o may mga bukol po kayong sa ngayon ay kailangan pong magpakonsulta sa specialist. At kung meron po kayong mga katanungan, meron po tayong chat box. Pwede po kayong mag-message dito. Tanungin po natin sa ating mga eksperto at sasagutin po nila yan. May lamang po during the open forum portion. So moving forward with our third topic. So I'm now giving the virtual floor to one of our medical officer of the Department of Internal Medicine, Dr. Cinderella M. Hernatirao. Good morning po, Doktora. So yun na po, we are joined by group. So madami po ulit tayo ngayon, no? So Doc Cindy, good morning po.
Hi, good morning, sir. Good morning po to everyone.
Are you going to share po yung sinan niyo po or ikaw na po?
Sige, ako na lang, sir.
Sige po. Okay po.
Sige po. Thank you. Ayan. Okay. So, good morning, everyone. I'm Cinderella M. Hernatirao, and I will be presenting our medical standpoint regarding sarcoma. So sarcomas are rare solid tumors, so only 1% of adult malignancies and 15% of childhood malignancies. They can be divided broadly into sarcomas of the soft tissue and sarcomas of the bone. Just like yung diniscuss ng previous colleagues natin, yung sarcomas of the bone. So, here, osteosarcoma is the most common type of bone cancer, just like what was mentioned. It usually occurs around the knee or shoulders, and the median age for all patients with osteosarcoma is usually 20 years. Osteosarcoma starts in the bone-forming cells called osteoblasts. So this the cause of osteosarcoma is usually not known, pero others usually it runs in the family. So osteosarcoma is commonly found in large bones, in the area of bones with the fastest growth rate. However, it can occur or pwede siyang makita in any bone. So osteosarcoma tends to occur in bones of the shin, yung malapit sa tukod, sa thigh, upper arm, or malapit sa balikat. So, pain, just like what was mentioned, pain and swelling are the most frequent early symptoms. So, pain is often intermittent in the beginning, and a thorough workup sometimes is delayed because maybe the symptoms could be confused with growing pains, especially sa mga bata. So, usually, osteosarcoma, they spread hematogenously or kumakalat sila uh, uh, through the blood. So, and usually sa lungs sila, sa lungs yung most common na site nila na ng kalat or metastasis na tinatawag natin. So, for soft tissue sarcoma, there are actually over 50 types of soft tissue sarcoma. Soft tissue naman is found everywhere in the body, katulad ng muscles, fat, and nerves. So, soft tissue sarcomas form most often in the limbs, like the arms and legs, followed by the torso or dun sa trunk, and the chest, abdomen, and back. So, what are the risk factors of having this type of cancer? So, usually, a small number of people, they carry a mutation or change dun sa genes. This mutation, it increases the risk of developing sarcoma. Those with such mutation are said to have hereditary or genetic syndromes. Actually, we inherit our genes from our parents, and in hereditary or genetic syndrome, your siblings, your parents, siblings, and your grandparents often have the same mutation. So it is important that you share what you know about your family history with your doctors. So this helps us determine if you may benefit from genetic testing. So if so, a genetic counselor may speak to you about the results, and yung genetic counselor, they are experts who has special trainings in genetic disease. So, multidisciplinary team. So prior to the initiation of treatment, all patients should be evaluated and managed by a multidisciplinary team because sarcoma is rare and often complex. So treating sarcoma takes a team approach. Treatment planning should involve a team of doctors from different fields of medicine who have experience in your type of sarcoma. So first is the medical oncologist. A medical oncologist treats the cancer adult using systemic therapy. This person often leads the overall treatment team. Next is the pathologist. A pathologist diagnoses a tumor by studying cells and tissue under microscope. A diagnostic radiologist read the results of X-rays and other imaging tests such as MRI or CT scan. And then an orthopedic surgeon, they perform the operation to remove the soft tissue and bone sarcomas that involve the pelvis, spine, and extremities. So they perform salvage surgery and reconstruct the bones after a bone tumor is removed. So surgeons naman, they perform operations to remove cancers from the torso, abdomen, and sometimes the extremities. So for the radiation oncologists, they prescribe and plan the radiation therapy to treat the cancer. An interventional radiologist naman, they perform the needle biopsy of tumors and sometimes ablative therapies. So another is the physical and occupational therapies. They help people recover from surgery and build strength, mobility, and resume the daily task. So during and after the treatment. And a dietitian or nutritionist, they help meet your nutrition needs during your treatment or yung tinatawag natin na nutritional build-up. Yan. So dito sa BGHMC, we have a tumor board held every Wednesday to discuss the patient's cases and plan for best appropriate treatment for the patients. So because there is a study that adherence to evidence-based recommendation is particularly important. And analysis shows that when we adhere to yung guidelines-based na treatment, it improved the survival outcomes of the patients. So for the workup and diagnosis, as discussed earlier, yung workup, it is done to establish the diagnosis and identify the extent of tumor and areas of metastasis. Yung metastasis or yung pagkalat ng tumor sa ibang parte ng katawan natin. So, initial workup include yung history and physical exam. So, this is where we interview you kung kailan nag-start yung nararamdaman, yung mga sintomas, tapos, and then we examine, we do physical exam thoroughly. And then, along with this, we perform imagings like CT scan, MRI, PET scan, X-ray, and bone scan. Yun. So, and then, we do the biopsy. So, biopsy is essential to confirm the diagnosis. Kung anong klaseng tumor or kung anong klaseng cancer yung sa patient. So, yung biopsy, it is the removal of sample tissue for testing. So, a diagnosis of bone cancer is confirmed using core needle or surgical biopsy. Yan. Yung genetic testing naman, it is done using blood or saliva, and the goal is to look for gene mutation na we inherited from your biological parents. Yan. Kasi some mutations, just like what was mentioned kanina, they can put you at risk for more than one type of cancer. Okay. For the treatment, your treatment options depend on the location and type of your sarcoma. So, just like what was mentioned kanina, the treatments are surgery, radiation, therapy, and then systemic therapy. So, here we will focus on the systemic therapy. So, the treatment can be local or can work throughout the body o yung tinatawag nating systemic or pwedeng both. So, yung local treatment, it treats the tumor directly. So, naka-focus siya, local siya, dun lang siya sa tumor. Yun. So, surgery and then the radiation, these are local treatments. Yun. So, chemotherapy naman, so for systemic therapy, yung sa buong katawan, examples are the chemotherapy, targeted therapy, and then immunotherapy. So yun yung mga systemic therapies. So systemic therapy, a cancer treatment that affects the whole body. Yan. So sa buong katawan siya nag-work. Chemotherapy, targeted therapy, and immunotherapy. Yan. So many systemic therapy are liquids that are injected into your veins or under your skin with a needle. So yung sa swero nilalagay. And then yung ibang chemotherapy naman, pwedeng as pills lang siya or yung iniinom by mouth. So, yung chemotherapy, it kills the fast-growing cells throughout the body, including yung cancer cells and the normal cells. Cancer cells kasi are fast-growing. Yeah, so there are many chemotherapy drugs that may be used to treat sarcoma. So, pwedeng more than one drug yung ibibigay sa inyo. So, most chemotherapy is given in cycles of treatment days followed by days of rest. So this allows the body to recover between cycles. So mapapansin niyo yung iba the chemotherapy could run for ilang days, 2 weeks, and then it will be followed by a rest of 2 to 3 weeks usually. Yun. So the number of treatment days per cycle and total number of cycles given also vary. So meron tayong tinatawag na neoadjuvant, adjuvant, and palliative na chemotherapy. So most sarcomas are treated with chemo before surgery. Ang tawag natin doon, neoadjuvant chemotherapy. So, ibig sabihin, binibigay yung chemotherapy bago dun sa surgery. So in some people with sarcoma, this can shrink the tumor which might help the surgery easier. So ang role neto is pinapaliit muna natin yung tumor para mas madali siyang operahan. So chemo is then given again after the surgery. Ang tawag naman doon is adjuvant chemotherapy. So yung chemotherapy na binibigay after ng surgery. Yun. Meron din naman tayong tinatawag na palliative chemotherapy. So palliative chemotherapy is typically used when the cancer has spread and chemotherapy is not used to cure the cancer. So ito yung binibigay para dun sa mga patients na meron na yung mga kalat or metastatic na tumors. Yung tumor nila nag-spread na or kumalat na sa ibang parte ng katawan. Yan. So ang goal ng palliative chemotherapy is hindi na i-cure yung cancer, but the main goal of palliative chemotherapy is to improve the quality of life ng patient. So meron din tayong tinatawag na chemoradiation, the treatment that combines chemotherapy with radiation. So chemotherapy may improve how well radiation works, and that is why they are sometimes used together. So it is a combination of systemic and local therapy. Meron ding targeted therapy. Targeted therapy is drug therapy that focuses on specific unique features of the cancer cells. Targeted therapy isn't used for every sarcoma, so it might be used alone or with chemotherapy. And the last is immunotherapy. So the immune system is the body's natural defense against infection and disease. It is a complex network of cells, tissues, and organs. So immunotherapy increases the activity of your immune system. By doing so, it improves your body's ability to find and destroy the cancer cells. Yun. So, syempre, along with these therapies, there are also, these therapies can cause side effects. Meron din siyang kaakibat na mga side effects. So, usual common side effects are nausea and vomiting, loss of appetite, diarrhea, hair loss, and mouth sores. So, a major concern with chemo used to treat sarcoma is that it can lead to dangerously low white blood cell levels and an increased risk for serious infection. So, because of this, drugs called growth factors may be given along with the chemotherapy to help the body make new white blood cells as quickly as possible. So, minsan bumababa yung WBC natin sa dugo. Yun yung panglaban natin from infection. So usually, pag bumababa yun, we give, meron naman tayong binibigay na gamot, what we call GCSF, para bumalik sa normal. Yun. So, most naman ng side effects ng mga chemo drugs, excuse me, they tend to go away after the treatment is finished. So, often there are ways to make these side effects less severe. Excuse me. So, for example, we can give drugs that help prevent or reduce the nausea and vomiting, or to help get the blood counts back to normal levels. So, during the treatment, be sure to discuss any questions you have about the side effects with your doctors, and feel free to express if you have or experiencing the side effect, so we can control and give medication to control these side effects. Okay, for summary, osteosarcoma is the most common type of bone cancer. So, bone cancer can metastasize to the lungs and other bones. Tests are used to plan treatment and also check how well the treatment is working. Systemic therapy is the use of substance to treat cancer cells throughout the body. And chemotherapy, targeted therapy, and immunotherapy are types of systemic therapy. So it is important to find a treatment center or hospital that has expert or multidisciplinary team with experience in your type of cancer to help you in the treatment of your cancer. So that's all. Thank you very much.
So may we give a virtual round of applause to Dr. Cinderella M. Hernatira for that presentation po. Maraming salamat po, Dr. Cindy, no? So, ayun nga po, kailangan po talaga ng multidisciplinary team approach in managing these types of different sarcomas. Okay, so moving forward with our last topic for today's Usapang Salun-at, I'm now giving the floor to our medical specialist 2 of the Department of Radiology, Dr. Armil Klein P. Maldonado. Good morning po, Doc.
Okay na po ba yung screen ko?
Nag-share pa lang po, Doc.
Share, let me just check.
Ayan po, pa-presenter's view na lang po, Doc.
Ayan, okay na po.
Ayan po.
Hello, good morning everyone. So I would like to thank the Department of Orthopedics for inviting me na magsalita dito sa talk natin, as well as kay Sir Ryan for this presentation. I am Dr. Armel Klein Baldonado, radiation oncologist of our institution, BGHMC. So yung title ng aking talk would be Radiation Therapy in Sarcoma, Why, When, and Where. So ang objective ko is to discuss the role of radiation therapy in extremity soft tissue sarcoma or STS, and ma-review natin ang steps in treating patients with extremity soft tissue sarcomas. So as an overview, nasabi na to kanina ng mga doctors na nagsalita kanina, ang sarcoma ay isang rare na disease kung saan 1% of all adult malignancies lang. And sa pediatric malignancies, around 15 to 20% ang nagkakaroon ng sarcoma. Heterogeneous group of tumors, ibig sabihin po nito, madaming subtypes of sarcoma. So, pero ang pinaka-main na pangalan niya, sarcoma. So, minsan makakarinig kayo ng leiomyosarcoma, rhabdomyosarcoma, liposarcoma, fibrosarcoma, angiosarcoma, osteosarcoma, or chondrosarcoma. So, ang pangalan ng mga tumor na to would depend on the location of origin. So, ito nakalagay naman sa screen ko, no? So, example lang, kapag nanggaling sa skeletal muscle, rhabdomyosarcoma. Kanina na-discuss, kapag nanggaling sa bone, osteosarcoma. So, yun lang, example lang yung mga yun. Ngayon, ang sarcoma, distributed siya all throughout the body. Pero ang pinaka-common site would be the extremities. Extremities, ibig sabihin, yung mga kamay, paa natin. So, 60% ng mga sarcoma ay located in the extremities. And kumpara sa upper and lower extremities, ang pinaka-common would be on the lower extremities. So, dyan yung mga thighs, yung mga leg and feet, no? Pero pwede din to mangyari or ma-locate sa trunk or sa katawan as well as the head and neck. Again, nasabi ko na to kanina, 1% only of malignancies and 80% ay soft tissue sarcomas. Kasi madami, nasabi ko nga, madaming mga klaseng sarcomas. And 20% originating in the bone. The median age of STS ay 45 to 55 years old. So yun yung mga median age niya, no? Pero mas common ito sa mga matatanda, more than 60 years old. So almost 50% ng mga kaso ay age 60 years old. So, age by histology, depende din kung anong age mo yung pinaka-common na sarcoma. So, sa mga 60 to 69 years old, common ang liposarcoma or yung malignant fibrous histiocytoma. Nasabi din kanina nung presenter natin sa PIDYA na meron din mga specific na sarcoma na common sa mga kabataan. Other risk factors. Mas common ito sa mga kalalakihan, male gender. Genetic predisposition, ibig sabihin, pwede din po itong mamana sa family, no? Kaya very important din kapag ganito ay makikipag-consult din tayo sa ating sa ating geneticist. Prior exposure to radiation or chemotherapy, chemical carcinogens, chronic irritation or lymphedema. Or pwede din ito ay, yes po?
Doc, sorry for the interruption. Doc, hindi po ata nag-move yung slide po ninyo. Nasa first slide pa lang po.
Ay, nasa first slide pa din?
Nag-move naman na po, Doc.
Nasa risk factors na ako. Kita po ba?
Epidemiology po yung nagpa-flash po. Ayan po, Doc. Okay na po.
Risk factors. Okay na
Yes
po ba?
Doc. Yes po.
Okay. Pasensya na po medyo mabagal ang internet natin. So, sa slide na to, sabi ko kanina, common ito sa sa kalalakihan at pwede ito mamana family, no? Genetic predisposition. Pwede din itong makuha sa mga viruses gaya ng HIV/AIDS or HHV8 involvement sa Kaposis or Kaposis sarcoma na tinatawag natin. So, sa next slide na tayo, nakikita po ba?
Risk factor pa rin to.
Anatomy, nakikita po, sir?
Still on the risk factor po, Doc.
Wait lang bakit kaya mabagal to? Let's just check ko lang po Bakit kaya? Hold on. Ayan, kita na po?
I still sharing, starting to share content ko.
Okay.
Ayan, Doc, anatomy na po yung nagpakita.
Okay, sige. So, anatomy na tayo, no? Ang STS or soft tissue sarcoma arises from the mesenchymal cell of origin. So, ito yung mga sa buto, sa blood vessels, mga muscles, ganyan. It can occur in all body types, nasabi ko na to, pinaka-common nga sa extremities. At diagnosis, 90% of extremity STS are localized to muscle compartment. So, nandun lang sa umpisa kasi nag-uumpisa lang siya sa specific area of the body, no. For example, dun nga sa muscles, mag-originate lang siya on one area and then usually mag-spread out siya. The most common STS by site, kunyari sa extremity nga, liposarcoma, malignant fibrous histiocytoma, synovial, and fibrocytoma. And sa other sa other areas like retroperitoneal, pwedeng magkaroon ng well-differentiated and differentiated sarcomas. And sa visceral, ang GIST. Ang sarcoma ay may other compartments, kumbaga. So, yung mismong bukol at saka surrounding it, ang tinatawag nating pseudocapsule, kung saan ito ay ang region of compressed reactive tissues. And surrounding it, ang reactive zone, kung saan nagkakaroon ng pamamaga or edema. Yung edema na to, makikita natin sa MRI or sa CT scan. And most likely, pwede itong mag-harbor ng microscopic diseases. So, hindi lang yung mismong bukol ang pwedeng puntahan ng tumor cells, pwede din dun sa surrounding areas niya. So, that's the reactive zone. Clinical presentation. Next slide na po, kita.
Anatomy, Doc.
Okay, sige, hintayin natin ah.
Mukhang mabagal lang, Doc, yung transition.
Mabagal lang. Pasabi na lang po kapag meron na, no, para ma-discuss ko.
Sige po, Doc.
So anyway, on my current slide, clinical presentation, usually ang sarcoma or STS nga ay site-dependent. Ibig sabihin kung saan yung pinagtubuan ng tumor, yun din yung magiging symptoms ng pasyente. For the extremities, usually enlarged painless mass. Or strain or hematoma. The symptoms of compression includes new onset edema and or new or worsening paresthesia or parang nakukuryente yung mga kamay, no? Karamihan ng mga pasyente ko na pumupunta sa akin, ang history nila, one example, meron akong patient na pumunta lang sa amin dahil ng paa, yung thigh. Afterward, napansin karon na ng bukol. So, pinasot lang nila thinking na baka napagod lang from hike or nauntog lang. Carefully, and lumaki yung bukol. And then from there, na doctor and then na-assess na merong sarcoma na. Meron din yung ibang pasyente, isang na pumunta sa akin na siya on the forehead. And afterwards, naroon ng sugat, non-healing wound, tapos biglang lumaki, akala nila, trinit nila for infection lang, yun pala, sarcoma na. Sir Ryan, nakikita po ba na yung clinical presentation slide ko?
Still on anatomy po, Doc.
Grabe, wait lang ah. Wala pa.
Clinical presentation na po.
Okay, sige. So nasabi ko na clinical presentation depending sa site, extremity, painless mass na lumalaki. Minsan dahan-dahan lumalaki. Meron din mga aggressive tumors na mabilis talaga lumaki. For the abdominal or retroperitoneal, minsan ang mga pasyente kapag nasa tiyan na nga yung tumor, hindi nila mapapansin kasi andyan yung intestines and other organs na gumagalaw lang. And if ever lalaki na yung bukol, dun lang nila mapapansin na parang may makakapa sila or minsan mabilis silang mabusog or parang early satiety, alteration in bowel or bladder habits, inability to lose weight kasi nga lumalaki yung tumor, no? So, other patients naman, they come to me na metastatic na. Ibig sabihin, stage 4 na, ibig sabihin, meron na pong kalat sa ibang parte ng katawan. So, most likely 6 to 10% have metastatic disease at presentation. And because of this, they have a higher risk. Itong mga patients na to have a higher risk in deep tumors and high-grade tumors. So, the more na pinapatagal mo na palakihin yung bukol, the more na nagkakaroon na ng sugat and increase in size nga yung bukol, higher chance din na pwede din siyang kumalat sa ibang parte ng katawan. Actually, ang pinaka-common site na pwede niyang puntahan would be the lungs. So, yun. Next slide. Kita na, ma'am siya. Ma'am siya, kita. Next slide. Hindi kita. Sir Ryan?
Prognostic factors.
Okay na. Sorry. So, prognostic factors, yun, meron tayong tinatawag na grade, yung size ng disease. Kapag, yun nga, nasabi ko kanina, habang lumalaki yung tumor, mas pangit yung nagiging prognosis or outcome nga ng sakit ninyo. Metastatic, ibig sabihin kapag kumalat na nga sa ibang parte ng katawan, sabi ko, around 6 to 10% at presentation. Factors increasing the local failure habang tumatanda, more than 50 years old, yung mga pasyenteng nag-recur ulit, so nagkaroon ng, meron na siyang sarcoma before, and then naulit, so, at saka yung mga margins less than 1 centimeters, no? Factors increasing the risk of distant metastasis naman, kapag mas mataas yung grade, mas mataas din yung chances na kumalat sa ibang parte ng katawan. Yung sa size, nasa 5 centimeters, more than 5 centimeters, mataas yung chance na naman. Deep-seated tumors or yung mga malalalim na tumors. And again, nasabi ko, recurrence as well as high-grade histologies. Next slide. Natural history. Sir Ryan, okay na ba?
Hindi pa rin daw. Prognostic. Ayan po, natural history.
Okay, sige. Natural history. So, ang pinaka-common na pwedeng daanan ng pagkalat ng soft tissue sarcoma is hematogenous, ibig sabihin sa dugo nga. So, from the local site, let's say, nasa thigh area, pwede siyang pumunta sa ibang parte ng katawan. Nasabi ko kanina, pinaka-common, 75% would be the lungs. So, kaya yung ibang mga pasyente din na kunyari meron na silang malalaking bukol na nagre-present na ng hirap huminga, pag-uubo, minsan meron din dugos yung ubo, mataas nga yung chance na iisipin ng doktor, baka kumalat na nga ito. Pero ma-prove lang natin to kapag mag-CT scan tayo. So, that's one important imaging. Pwede din pumunta sa bone marrow, sa liver, sa brain, pero hindi common sa utak, no? And pwede din sa mga kulane. So, may mga certain histologies para sa mga residents natin na common na pumunta sa lymph nodes. Ito yung clear cell, angiosarcoma, rhabdomyosarcoma, as well as yung epithelial sarcomas. So, care histologies. And again, for our residents, staging, kita po ba? Next slide.
Natural history lang.
Okay, sige, hintay lang po tayo. So, sa staging naman, sa mga lay natin, no, meron tayong tinatawag na AJCC staging. So, meron yung stage 1, stage 2, 3, and 4. 4, ibig sabihin lang nito, kumalat na sa ibang parte ng katawan. So, distant metastasis ang tawag dito. Pwede ka din maklasify as stage 4 kapag nakita na meron ng tumor sa kulane. Sa stage, magiging stage 1 ka lang kapag mababa lang yung grado, kumbaga, nung tumor. So kapag grade 1 tumor ka lang, kahit malaki pa yung bukol, automatic stage 1 na yan. Meron tayong stage 1A, stage 1B. And the rest ng mga bukol nasa gitna na, nasa stage 2, stage 3A, and stage 3B. So para lang madaling maalala, kapag low grade, automatic stage 1. Kapag metastatic, distant metastasis, tapos meron na sa kulane, automatic stage 4 na. And the rest in between, stage 2, stage 3. Okay? So, kita po ba? Staging? Magna-next slide na sana ako. Sir Ryan?
Yes, Doc. Yes, Doc.
Okay na.
Next slide.
Okay. Sige, I'll go to my next slide. Management of extremity soft tissue sarcoma. Nasabi ni Doktora kanina na very important yung multidisciplinary discussion. So, dati kasi pag nakuha ng isang doktor yung isang kaso, siya na mismo magmamanage. Pero ang kagandahan ngayon, madami ng mga doctors, madami ng specialist na mag-handle sa patients natin. No? Ibig sabihin, madaming mga utak na magdi-discuss kung ano yung best para sa patients natin. So, swerte tayo dito sa BGH. Every Wednesday, meron tayong multidisciplinary discussion. So, meron po tayo dito yung medical oncologist nga natin, Pedia Hema-Onco, surgical orthopedic oncologist, ako, radiation oncologist, and other departments, radiology, very important for the imaging, as well as yung pathology kasi sila magko-confirm na sarcoma nga yung isang bukol. So, yung team namin, every Wednesday nga, pinag-uusapan lahat ng mga cancer, no? Bago pa natin bigyan ng assessment as well as treatment. Kasi gusto natin, bago tayo gumawa ng move, kailangan sigurado muna tayo. And then, syempre, ang lagi nating iniisip dito, yung best for the patient. So, it's very essential, and again, we are very lucky na ginagawa natin to sa lahat ng mga patients natin here in BGH. So, here, the evolution of treatment. Dati kasi, nasa next slide na po ako. Evolution of treatment.
Yes po.
Okay. Dati, ang ginagawa, historically, after ma-diagnose ng soft tissue sarcoma, amputation na. So, tinatanggal na yung paa or upper extremities nga. Pero, ang kagandahan, nagkakaroon ng evolution nagkakaroon ng improvement sa treatment. So, right now, ang ginagawa na natin, limb sparing surgery. And dito na pumapasok yung other treatments gaya ng radiation therapy as well as chemotherapy. So, ito, surgical management, sabi ko nga, amputation ang ginagawa dati. Kaso, nung bandang 1982, merong mga nag-study under Rosenberg na pwede na nating mag-do away from removing the extremities or amputation, and instead of that, limb sparing, tatanggalin lang, kukunin lang muna nila yung large part of the tumor, and then afterwards, magbibigay kami ng radiation therapy. So, yun na, usually ang ginagawa natin. Pero syempre, there are instances din, assessment din ng mga orthopedic oncologist na kung kaya pang ma-save or ma-salvage yung limb or hindi na. So, again, babalik tayo sa MDT. Pinag-uusapan namin yan para malaman natin kung ano yung pwede nating option or gawin for our patients. Okay? In this study kasi, nakita na there's no difference in the local failure, disease-free survival, and overall survival. Ibig sabihin, yung mga pasyenteng na-amputate versus yung mga pasyenteng inoperahan plus nag-radiation plus nag-chemotherapy, pareho yung naging survival rate nila. Kaya sa ngayon, ang nagiging trend, gusto natin salba or ma-save muna, ma-save yung mga extremities natin. Okay? Para din for the patient, yung tingin niya sa sarili niya, at least kompleto pa, yung sa mental health nila, it would be better. Comparing for patients na natanggalan ng part ng extremity. So, I will be discussing about radiation therapy na, no? Andito na po ako sa slide ng adjuvant radiotherapy.
Yes, Doc.
Okay. Adjuvant radiation therapy, ibig sabihin, after surgery. So, yun yung ginagawa dati, until now naman. And ang basis of our study dito, meron kasi before, under the National Cancer Institute, for 141 patients na nagkaroon ng soft tissue sarcoma, kinompare nila yung limb sparing surgery. So anyway, na-discuss ko naman na yun para lang at least maintindihan nyo. Limb sparing surgery, ibig sabihin, tatanggal lang sila ng wide excision of the tumor and then afterwards magbibigay tayo ng radiation therapy and chemotherapy. So nakita nga nila dito na yung comparing patients who only had the limb sparing surgery and for those comparing it to those patients who had radiation plus or minus chemotherapy, ang local recurrence ay nag-improve. So wala. Dito sa study na to hindi na ulit yung tumor. Ang overall survival din after 20 years ay better sa mga nag-undergo ng radiation plus chemo, 71%, kumpara sa mga nag-limb sparing surgery which is 64%. So almost basta it's there's an improvement sa survival kumbaga. Okay. So dito medyo technical na. I won't be discussing this. Here, benefits of pre-operative radiation therapy, Sir Ryan, kita?
Benefits of pre-operative RT.
Okay. Kanina, diniscuss ko yung timing ng radiation after the surgery. What if gagawin natin yung radiation prior to the surgery? Nagkaroon sila ng studies din before and nakita nila na possible din. So, pwedeng gawin yung radiation bago surgery, pwedeng din gawin after surgery. So, magdedepende na lang kung ano yung case ng patient. So, ang benefit nito, lower yung radiation dose, smaller yung treatment volume, and mas konti din yung long-term na toxicity which includes fibrosis and joint stiffness. Mamaya ipapakita ko, may slide ako dito, makikita natin yung comparison kung ano ba mas maganda, yung pre-operative or post-operative radiation therapy. So ito na yung slide na sinasabi ko. Kita nyo na po ba? Pre-operative versus post-operative radiation therapy?
Not yet, Doc. It's still on the benefits.
Sige. Let's wait na lang. This is a nice slide for our residents.
Okay na po, Doc.
Okay. Para at least makikita natin kung ano yung not better naman, but at least we can give an option for our patients then. So pre-operative RT, again, sa mga kasamahan natin, pre-operative ibig sabihin bago operasyon, post-operative after the surgery. So benefits for the dose, mas konti yung dose na naibibigay natin sa pre-operative RT. Ang ibig sabihin nito, kung mas konti yung dose na ibibigay natin, yung side effects mas konti din. smaller treatment volume sa pre-operative kumpara sa post-operative. Kasi kapag post-operative, ibig sabihin nito natanggal na nga yung bukol kaso may mga surgical markings na ginawa. And because of that, tatamaan din ng radiation oncologist yung part na yon. Rate of wound complications, acute to. Mas madami sa mga pre-operative. Kasi after the radiation, yung oxygenation ng area na yon ay bumababa. Kaya kung mapapansin, sa mga patients na nag-radiation bago yung surgery, nagkakaroon ng acute complications. Pero, manageable naman to. Hindi naman ito tumatagal. Acute, ibig sabihin, mabilis lang. And for the post-operative radiation therapy naman, mas mataas naman ang late toxicity. So, pre-operative, acute toxicity, post-operative, late toxicity. Late toxicity, ibig sabihin, mga side effects ng treatment na medyo matagal bago magpakita. Tulad ng fibrosis or paninigas ng muscles, edema, pamamaga, or joint stiffness. So, yun yung mga features ng pre-operative and post-operative. Either way, wala naman nagiging problem. So, pwede nating gawin it's either pre-operative or post-operative. Pero dun sa NCCN guidelines, ang mas fini-favor nila would be the pre-operative kasi nga mas konti yung dose na ibibigay at saka mas yung volume ng treatment natin mas maliit din, which is better than for the patient since yung complications would be less. Okay, ito yung sinasabi kong NCCN guideline. Kita po ba? Anyway, again, medyo technical na to. I won't delve into this na lang. Ito na, important part of my discussion para alam ng mga kasamahan natin paano ba natin ginagawa yung radiation. Kita na po ba yung radiation therapy flow?
Still, yes po, Doc. Okay na po.
Okay. So, pag dating ng pasyente sa akin, what I usually do, ko-consult natin siya, no? History, physical examination, together with this, aalamin din natin lahat ng mga ginawa sa kanyang imaging, gaya ng CT scan, MRI, and then kapag ano pa yung mga simptomas niya bago siya maoperahan. Or kung hindi pa naoperahan, kung planong mag-pre-operative, okay din lang naman. After nito, CT scan simulation, isi-CT scan ko yung pasyente, contouring, idodraw ko yung target natin, planning endosimetry, and then delivery of the treatment. Mamaya, may mga pictures ako para at least ma-appreciate nyo. So, next slide, CT scan simulation. Kita na po ba?
Still, yes, Doc. Okay na po.
Okay. For the CT scan simulation, so lahat ng mga pasyenteng mag-undergo ng radiation therapy, kakailanganin natin i-CT scan ulit. Tatanungin ng mga pasyente, Doc, bakit ulit ako isi-CT scan? Kaka-CT scan sa akin ng ortho. Ang sasabihin ko po, itong CT scan na ginagawa po namin ay planning CT scan or CT scan simulation. Kasi po, important ito since ito na yung magiging posisyon ng pasyente during the course of treatment. That is why important din kaming gumamit ng mga immobilization device. As you can see here sa picture, meron kaming tinatawag na vacuum lock, no? So, ihuhulma namin yung area of treatment dun sa lock na to para hindi maigalaw ng pasyente. So, depende din yung scan namin kung ano din yung location ng tumor. So, next slide. Kita na po ba yung picture nung paa?
CT scan, Doc.
Okay. Anyway, dito sa during the CT scan simulation then, it's very important for us also to take note of the scars. So, sa picture na to kasi makikita na naoperahan na yung pasyente and madami ng scars na kikita, no? So, nilalagyan namin ng marking to para makita ko sa scan since this would be included in my treatment area.
Yan po, yung picture na po, Doc.
Okay, so yung picture na, no? Okay, so makikita nyo dyan yung marking natin ng scar. So medyo mahaba, no? Kasi naoperahan na. So yun yung sinasabi kong another disadvantage. Larger yung treatment area kumpara kung hindi pa naoperahan, dun lang sa site of tumor yung irradiate natin. Okay, next slide na po, contouring.
Yes, Doc.
Okay. Makikita nyo dito sa picture, no? Picture A and picture B. Yung color red dito, ito yung mismong tumor na dinodrawing namin ng radiation oncologist. Kasi ito yung ita-target natin. After that, maglalagay lang kami ng margins. Ito yung color yellow and color green. Yan po yung margins po natin. Kasi kaya naman tayo naglalagay ng margin kasi there are chances na hindi, nasabi ko kanina, na hindi lang sa tumor yung mga tumor cells eh. Meron tayong tinatawag na micrometastasis na pwedeng kumalat dun sa mga surrounding areas. Kaya naglalagay tayo ng margin. Aside from that, yung margin na to, para din kapag gagalaw yung pasyente, at least yung target natin, matatamaan pa rin natin. So, next, kita po ba yung picture?
Still on contouring. Ayan po, okay na lang.
Okay, on this image, patient namin to na may sarcoma nga, soft tissue sarcoma on the left thigh area. So, kung makikita ninyo dito, yung color yellow, ito yung scar. So, yan. Tapos yung red, yan naman po yung drenowing namin for the target. So, itong part na to, buong to, yung nakikita yung kulay red na yan, yan yung tinatamaan natin. So, again, ang radiation therapy is a local treatment. So, kung ano lang yung nakikita namin on the scan, yun lang din po yung tatamaan natin. Kumpara sa chemotherapy, which is systemic, buong katawan yung gamot pumupunta. For radiation, local lang. So, dun lang sa area. And then here, for the dose naman, para at least alam ninyo kung ilang araw ba natin ginagawa yung radiation. Kita na po, sir, dose fractionation.
Still on the picture, Doc. Ayan po, actual treatment.
Sige. So, dose
fractionation.
fractionation. Oo. Dito na natin maririnig nyo yung doctor, 50 gray, 60 gray. Gray, yun lang po yung unit of measurement natin for radiation. Pero mas maintindihan nyo kung ilang araw na lang yung nagiging treatment natin. Kung pre-operative, usually nasa 25 days lang yan. So, ang treatment ng radiation, ginagawa natin during the weekdays lang, Mondays to Fridays, except Saturday, Sunday. Bakit hindi pwedeng dire-diretso? Ginagawa natin na Mondays to Fridays lang and then nagre-rest tayo for Saturday, Sunday kasi kailangang mag-rest din or mag-heal yung mga normal tissues surrounding the tumor, no? Para come Monday, okay na ulit. Kaya na naman ng katawan na mag-initiate ng radiation therapy. For post-operative naman, ito yung sinasabi kong mas matagal yung nagiging treatment. Kasi kakailanganin natin ng additional radiation dose kung saan pinagtanggal na ng tumor. So, initially, 25 days and then nagdadagdag tayo ng additional na mga 5 to 10 days na treatment. So, mga 30 to 35 days yung nagiging therapy kapag post-operative. Kumpara sa pre-operative, 25 days lang yung treatment natin. Okay, next slide. Actual treatment of the patient.
Still, ayan po, Doc. Okay na.
Okay. So sa slide na to, makikita natin yung machine natin. Ang tawag dito linear accelerator. So ang position ng pasyente nakahiga lang and then meron tayong rad tech dito na mag-a-assist sa patient. Ipo-position yung pasyente and then afterwards lalabas din. Kasi during the course of treatment, dapat walang tao sa bunker. Kasi mataas nga po yung dose na nare-receive or lumalabas from the machine. Okay? So again, nakita nyo dito, each treatment, it's 10 to 15 minutes lang, Mondays to Fridays, except weekends as well as holidays. I will be sharing a video. Kita po ba?
Hindi pa po.
Sige. Actually, gawa ito nung pasyente. Very nice yung documentation niya, kaya nagpaalam ako na ipakita din sa inyo.
Ayan na po, Doc. Nag-play na po.
Yan. Nagple-play. Sige. So, makikita nyo dito, isang patient namin na may soft tissue sarcoma on the left thigh nga. Nung umpisa, masyadong malaki yung bukol. Kaya, hindi ideal yung naging setup namin. Nag-radiation muna kami for 10 days, and then high dose, and then afterwards, nag-chemotherapy yung patient. After the chemotherapy, nagkaroon ng improvement sa balat niya, and nag-decide na mag-limb sparing surgery. So, hindi tinanggal yung paa niya, no? Yung mismong bukol lang. And since kulang yung naging radiation namin, 10 araw lang yung binigay namin nung umpisa, nag-decide kami na kumpletuhin yung radiation hanggang another set of 25 days. Actually, yung patient ngayon ongoing, hindi pa tapos dun sa second course of radiation niya. Pero sa video, makikita ninyo na napakaganda nung naging outcome ng treatment, yung surgery niya, very nice. So, yun yung advantage ng multidisciplinary team. Magkakasama ang surgeon natin, ang radiation oncologist, as well as our medical oncologist for the chemotherapy. So, yun. May mga katanungan din. Next slide na po.
Ayan po, Doc. When is RT not indicated?
When is RT not indicated? May mga pasyente magtatanong, pwede po bang hindi mag-radiation therapy? Actually, there are instances na pwede naman. Basta, stage 1 ka lang. At saka, yung grade nga and size ng tumor ay napakababa. Pero, hindi, discretion pa rin ng doktor yun, no? Hindi porke ganun nga, you met the criteria, hindi na tayo mag-radiation. There are instances na close margin na tinatawag, tinanggal yung tumor pero napaka liit nung margin. Kapag malapit to sa mga neural structures, kakailanganin, pag-uusapan namin sa team kung bibigyan pa ba namin ng radiation or hindi na. So, yun yung mga instances na pwedeng hindi na mag-radiation. Pero most of the time, kapag yung mga high-grade tumors nga, close margin, yun yung mga kakailanganin natin i-radiation after the surgery. So, ito na po. Huling slide ko na. Summary. Kita po.
When is RT? Yan po, Doc. Summary na po.
Okay, for the summary, para lang alam ng lahat, again, ang sarcoma, multidisciplinary approach siya, hindi lang isang doktor ang titingin sa inyo. Meron tayong surgeon, radiation oncologist, medical oncologist, as well as the rest of the multidisciplinary team. For the treatment, it's dati, sinabi ko nga, amputation, pero ngayon we are already going towards the limb sparing surgery. Pagkasunod nito, radiation therapy. And sa radiation therapy, pwedeng bago operasyon or after operation. Pero mas according to the guidelines, mas gusto natin gawin yung pre-operative radiation therapy. And again, for the chemotherapy, for the systemic treatment. So, ayun lang po yung discussion ko. Hopefully, naintindihan nyo, and good day po.
So maraming salamat po, Dr. Armil Klein Baldonado. Medyo po naliwanagan po tayo patungkol sa sarcoma po, no, sa inyong discussion. Napaka-komprehensibo po ng inyong discussion patungkol po sa sarcoma, Dr. Armil Klein. So, ayan po, si Dr. Baldonado po. Ayun, so At this moment po, no, before we proceed with the open forum questions, while waiting, kung meron po kayong mga katanungan, now is the time. You may now message us. Pwede po kayong mag-chat dito po sa ating message, dito sa ating chat box kung meron po kayong mga katanungan. And before we proceed with the open forum portion of our Usapang Salun-at, may we express our gratitude to our resource speaker. So allow me to read the content, and to our participants, may we give them a virtual round of applause. But before that, allow me to read the content. So Republic of the Philippines, Department of Health, Baguio General Hospital and Medical Center, Baguio City, Certificate of Appreciation is presented to Dr. Armil Klein B. Baldonado for sharing his time and expertise in the Usapang Salun-at sa Komunidad 2023 4th Special Edition with the theme Sarcoma. For your information, a multidisciplinary theme awareness held on August 4 via online Cisco WebEx, signed by the head of the Public Health Unit, Dr. Lea Mordi Fangonilo, and of course, our Medical Center Chief 2 of the Baguio General Hospital and Medical Center, Dr. Ricardo Birunas Jr. Same certificate of appreciation is also presented to Dr. Kim Daniel S. Fianza. Same certificate is presented to Dr. Kyle Paulo Idoba. And same certificate is also presented to Dr. Cinderella M. Hernatirao. Again, to our resource speaker for today's Usapang Salun-at on Sarcoma, for your information, multidisciplinary team approach, maraming salamat po. And we now proceed with the open forum portion of our activity. So, pa-stage na lang po yung ating mga resource speakers, Sir Ding. Ayan. So since I only have few questions po, Doc, before po nating mapakinggan yung inyong mga final key takeaway messages. So siguro anyone can answer po, no? Para lang po maintindihan, since lay people po yung ating mga audience po ngayon. And we've been talking about sarcoma, and yun nga po yung iba't ibang klase ng sarcoma. And it was discussed rin naman po na by Dr. Baldonado na ang mga tumor nga po, ang kanilang pangalan ay nakadepende kung saang lokasyon. Nasabi rin po niya ito na mas nangyayari ang pagkakaroon ng bukol sa ating mga extremities, and of course, mas common ito sa mga kalalakihan. Pero itong napakasimpleng tanong po na pre-registered question na pwede pong sagutin ng sino man po sa inyo po. Bakit nga po ba nagkakaroon ng bukol po ang isang tao? Doc Baldonado?
Hello po. Gaya nga po ng nasabi ko kanina, may mga predisposing factors, no? Sa pagkakaroon ng bukol sa katawan. Hindi naman po kayo may bukol ka ay cancer na. Meron pa rin tayong mga benign na mga bukol. Kaya kakailanganin pa rin natin na magkonsulta sa doktor, ipakita, and maprove natin lang ito na cancer or hindi through biopsy. And minsan sporadic eh. Hindi talaga natin masasabi kung kailan ka magkakaroon ng mga bukol na ito. Nasabi ko, there are certain age group na pwedeng magkaroon ng mga certain types of sarcomas. There are like sa mga matatanda, and then sa mga young age group, sa mga patients na nagkaroon ng mga viruses, just like yung HIV, HHV8 nga, yung mga may AIDS, pwede din silang magkaroon ng sarcoma. There are instances na dahil trauma, due to trauma, so may paulit-ulit na natatamaan yung certain part of the body nila na pwedeng magkaroon or mag-develop into a malignant tumor. So, aside from that, very important din yung genetic predisposition. So, kakailanganin talaga natin malaman yung family history natin, alamin natin kapag may mga kamag-anak tayong nagkaroon ng mga bukol, kung nag-cancer ba ito or hindi. So, yun po yung take natin dito. Hindi talaga natin masasabi, pero there are certain predisposing factors for this one.
Thank you, Doc Baldonado. So, yun rin po yung follow-up question po sana. So, basically, Doc, ang pagkakaroon po nito ay pwede rin pong namamana po, no? Eh, tinatanong po natin yung genetics, hereditary, kung meron po sa kanilang mga family members na nagkaroon rin po ng mga ganitong klaseng sakit even before po. Okay, Doc. Thank you po. And next question, Doc. Meron po kasing since community po to lay people, meron mangilan-ilan po siguro na wawalang bahala po na yung pagkakaroon ng bukol. So ang katanungan po, Doc, ano po ba yung usually po, Doc, kung kailang grabe na, dun na po sila nagpapa-check up po kasi. Okay. So ano po kaya, Doc, yung mga palaunang palatandaan na bago pag grumabe, ay kailangan ng magpakonsulta, magpatingin po sa isang specialista kung meron pong bukol ang isa pong tao.
Okay, no? So, kanina ang daming mga features na pinakita ng mga doctors natin, lalo na yung sa kay Dr. Idoba, no? Makikita ninyo ang lalaki na talaga ng mga bukol pagdating nila sa mga doctors. So, there are instances na slow growing ang tumor eh. Huwag nyo nang paabutin na parang bola na yung bukol na yan or nagkakaroon na ng sugat bago magpakonsulta sa doktor. So kung napansin nyo na meron unusual na bukol sa katawan, mas maganda na magpakonsulta kaagad sa doktor. And again, huwag kayong matakot kasi naisip ng mga ibang pasyente, malalaman nila kung kung ano yung condition nila, no? It's better for us to know your diagnosis right away kaysa malaman natin to na end stage na pala or stage 4 na. Although sabi ko nga nasa 5 to 8% lang naman, 5 to 10% lang naman yung mga metastatic. Pero again, wag niyo nang hintayin na magkaroon ng sugat yung balat na sobrang laki na yung bukol. Kayo ang nakakaalam sa katawan ninyo, kayo din makakapagsabi kapag may mga bago kayong bukol. Dapat maging proactive, magpakonsulta kayo agad sa doktor para mas maginhawaan kayo. O di at least kung nalaman yung benign lang pala, walang gagawin, pwede lang obserbahan, hindi na kayo matatakot. Pero kung nalaman ninyo na cancer pala, at least mabibigyan na natin kayo ng proper na treatment.
Ayun po, no? So, thank you, Doc Baldonado. So, thank you also, Doc, for sharing with us yung workflow po, no, yung radiotherapy from consultation, CT simulation, and from contouring, planning, and dosimetry, setup, and delivery of RT, and then the follow-up. And here's a question, Doc. Possible po ba, Doc, or what are the chances na bakit po, pag nakumpleto na po ba yung radiotherapy, Doc, pwede pa rin po bang bumalik yung bukol po?
Okay. So, ayun nga po. Uulitin ko na naman, multidisciplinary ito. Meron tayong hindi lang radiation, no? Meron tayong surgeon, orthopedic surgeon, our medical oncology for the chemotherapy and then the radiation therapy po, no? So, depende po kasi yung nagiging prognosis ng mga pasyente na to. For one, to begin with, yung pathology or yung grade ng tumor. Kapag very high grade yung tumor at saka napakalaki yung tumor, yung sinabi ko nga more than 5 centimeters, at saka dun sa surgery nahirapan yung na makuha lahat yung tumor, these are the factors na kino-consider natin for possible recurrence. And ang radiation nga po, local treatment ito, nakakatulong po para mabawasan natin yung local recurrence or pag-ulit ng tumor. Pero at a certain percentage. Hindi siya 100%. So there's still a chance for the tumors to recur. That's why it's very important for the patients to undergo follow-up. So yun yung nakalimutan ko, follow-up, very important. Hindi porket tapos na yung treatment niyo, hindi na kayo magpapakita sa doktor. I-advise naman kayo ng doktor kung kailan. Usually every 3 months yan, babalik kayo para magpa-physical exam ulit. And then kapag kakailanganin ng mga imaging like CT scan, sinabi ko sa very common site of the recurrence would be sa lungs. It's very important for us to do CT scan of the chest para malaman natin kapag kumalat na or hindi. And then MRI on the specific area kasi for soft tissue sarcomas of the extremities, MRI would be the best imaging. And again, it's your responsibility. Kapag sasabihin ng doctor every 3 months pero after 1 month, 2 months, napansin nyo meron na kayong panibagong bukol, it's better for you to go right away to your doctor para ma-manage na natin ito. So, yun po.
Thank you, Doc. Clean ulit. Doc, it's very nice to know rin po that we have this tumor board po dito sa hospital. Siguro, Doc, ang kailangang malaman rin ng tao or community, Doc, mahal po ba magpagamot ng taong may bukol? Yun po yung kailangan po siguro nilang malaman, Doc. May mga programa po ba na nalilibre po itong mga gamot or management ng mga taong may bukol po?
Sa akin pa rin po ba or sa other doctors?
Anyone can answer po, Doc.
Sige, ako muna. Regarding sa radiation therapy, ito na lang yung ma-share ko, no? So, karamihan nga ng mga pasyente, isang reason kung bakit sila nade-delay whenever I ask them kung bakit ngayon lang sila pumunta kasi natatakot sila, baka mahal nga yung babayaran nila, wala silang budget or yun nga, financial constraints, which is maintindihan naman natin. Pero it's very important for our lay people to know na may mga programs tayo. For as long na meron po tayong PhilHealth, libre na po ang gamutan. Hindi po mahal magpagamot. Importante lang pumunta kayo sa hospital, magtanong kayo ng mga options nga po. Meron din naman tayong mga social workers dito sa atin na makakatulong sa inyo. Again, for the radiation therapy, wala pong bayad dito kapag under kayo ng charity service and basta po intact po yung PhilHealth nyo din po. Yun po.
So, thank you, Doc Klein. So, that's very clear, no? As long as meron po tayong PhilHealth, no? Yung mga mag-undergo ng radiation therapy, that's free na po. Okay, so maybe also listen po to Dr. Kim Daniel Fianza. Ayan, so while waiting for Dr. Fianza, maybe listen to Dr. Idoba. In terms of services po, Doc, na in-offer po natin dito po sa hospital since yung sarcoma nga po, it requires a multidisciplinary team approach. So ano po yung pwede po nating ma-share po with the lay people po in terms of our services in managing po these types of yung sarcoma po. So while waiting for our resource speakers, Doc Klein, we have one question dito po sa ating chat box. Maybe we can entertain it po, Doc. So Doc, what's your stand regarding this one? Is it true that if you have alkaline pH of your body, will it prevent sarcoma po?
Maraming salamat po sa inyong katanungan. Actually, regarding this one po, wala pa po akong nababasa na studies na makakapag-support na kapag alkaline or acidic nga yung katawan niyo ay makakapag-prevent ng sarcoma or even any kind of cancer. So, for your question po, hindi ko po alam yung kasagutan. Pero sabi ko nga po, wala pa akong nababasang study or evidences na makakapag-support sa claim po na ito.
So thank you, Doc Len. Doc, one last question before we will be listening to your key takeaways. You've been talking about the management po kanina and may I just ask lang po, Doc, meron po bang role yung diet or kung ano yung mga pwede or bawal pong kainin ng isang taong may sarcoma po, Doc?
Lagi kong sinasabi sa mga patients ko. Kasi actually on the diet part, it's very difficult talaga na magkaroon ng association, lalo na kapag sarcoma, no? There are other kinds of cancer na pwede nating i-associate with cancer nga. Just like yung pagkain ng mga carcinogenic food, like mga inihaw na mga pagkain, or yung mga high in salt content na mga pagkain, pwedeng, or yung mga pagkain na high in, what do you call this, high in preservatives, pwedeng magkaroon ng mga cancer like nasopharyngeal carcinoma or gastric carcinoma. Pero in sarcoma, again, wala akong nababasang mga studies na pwedeng i-associate yung diet with sarcoma. And for patients who are undergoing radiation therapy, I don't restrict them naman. So, lagi kong sinasabi din sa kanila, for as long as yung diet ninyo ay complete, ibig sabihin, you're not restricted with your proteins, with your macronutrients, your fats, and the rest nga, then it's good. Another thing din na sinasabi namin sa mga patients, since mag-undergo not only for radiation but also for chemotherapy, bumababa po kasi yung immune system ng patients. That's why it's very important whenever they eat, sila sana mag-prepare ng meal nila and iwasan nila yung mga pagkain na hindi naluto. Since for a normal or a healthy individual, we can actually tolerate yung mga normal na nasa bacteria or microbes na nasa salad, let's say, no? For a patient na mababa yung immune system, they cannot tolerate it. That's why it's very important na laging cooked yung food and iwasan yung mga hindi nalutong pagkain. So, isa yun sa mga sinasabi namin. Not because of the cancer, but because of the decrease in the immune system.
Thank you, Dr. Klein. So for as long as complete po yung diet, it's okay po. So Dr. Garin is also raising his hands. Doc, would you like to say something po?
Yeah. Thank you again, Sir Ryan, and the Public Health Unit of BGHMC. Kami po ay masaya at nagagalak na bigyan mo kami. We must wait for this presentation. Now, the goal of this webinar is to strengthen our primary care health workers. Ito yung mga health center natin sa mga barangay. Ito po ay ayon sa universal health care. So, we pray and we hope that the primary healthcare workers from different regions of CAR has the necessary information and how to refer patients. Ang pray lang po namin is yung mga, kung mayroon kayong nararamdaman na o nakikita ng mga bukol sa kamay, sa paa, you don't have to go to BGHMC. Ang pupuntahan niyo muna is yung primary care physicians nyo sa health center o sino man, and you have your checkup from that doctors, and then yung doctors na yun, kung kaya, initial evaluation, ay okay lang naman po. Pero kung yung definitive management at ito ay talagang ang tingin nila ay cancer, you have to go to a tertiary hospital like BGHMC po. Kami po yung mga espesyalista na tumitingin sa mga ganitong klaseng sakit. So, yun lang po. And I hope we are very happy if we get one or two essential information from this webinar. Thank you very much.
So thank you, Doc Garin. So to everyone po, no, in the context of universal healthcare nga po, meron po tayong mga primary care facilities. No? Ito po yung mga tinatawag po natin ng mga health centers po, no? So, ang gusto po namin iparating ay sa ating mga kasamaan po sa community po, kung meron po kayong mga nararamdamang mga iba't iba pong sakit, ay pwede pong magpakonsulta po muna sa ating mga primary care facilities, sa ating mga rural health units or municipal health offices or city health offices, para po doon po muna nila titignan, dahil po ang universal healthcare ipupunta po lamang, i-refer po dito po sa tinatawag po na Apex Hospital, katulad nga po ng BGHMC, pag hindi na po kayang i-manage at the level po ng primary care facility, kaya tinatawag po natin siyang specialty cases. So yun po yung konteksto ng universal healthcare po na pinasa po na noong 2019, pinirmahan po ng dating Pangulong Duterte. So thank you for that, Dr. Garin. And we have siguro and we will entertain this one last question po, Doc, no? So from our chat box from Ma'am Salazar, Ma'am Marie Salazar. So there are food supplements, stem cell supplements advertised online claiming prevention of diseases and even cancer. Anyone can answer po, Doc, no? Ano po raw ang inyong stand regarding this one po? Okay, so let's start with Dr. Baldonado po ulit.
Hello. Actually, regarding stem cell supplements as well as other herbal na mga products, no? I keep on telling my patients na kung makikita nyo, there's dun sa mga labels nila, no approved therapeutic claims. So there are no studies yet that support the use of these supplements. And kaya nga siya supplement, dagdag lang sa ginagamit nga natin or sa actual na treatment, no? It's very difficult eh. I don't have a stand on this, pero lagi kong sinasabi sa patients na kung gagastos na din lang kayo, dun na kayo sa sigurado. Dun na kayo sa may pagbabasihan, dun na kayo sa kung saan meron talagang results na maipapakita. Kasi these supplements are very expensive eh. And some of the patients rely on these supplements only, thinking na they won't be needing the actual treatment, which is yung surgery, chemotherapy, and radiation therapy. And it's quite misleading then. Wala akong, I don't want to say anything bad about this, no? Pero, again, kung gagastos na din lang kayo, gumastos na lang kayo sa tamang treatment.
Thank you, Dr. Clay. What about Dr. Cindy Tirao? What's your stand for regarding this question po? Doc, we can hear you po. Wala pa rin po, Doc. Wala po. Wala pa rin po, Doc Cindy. Okay, so while waiting na inaayos ni Doc Cindy yung kanyang audio, may we listen first to Dr. Idoba. Doc Kyle, what's your stand po regarding this question?
Sir?
May I ask your stand po regarding this question po raised dito po sa ating chat box, Doc Kyle?
Ano po? Wala. Nasa province. Sorry, hindi ko mabasa.
Okay, I'll read na lang po once again, Doc Kyle. There are food supplements, stem cell supplements advertised online claiming prevention of diseases and even cancer. What's your stand regarding this one, Doc?
Regarding food supplements, vitamins or anything po, Doc, in relation to sa tumors po or cancer, di may provide po yung benefit sa mga ingredients niya or components niya, pero di din kasi or not clearly sure dun sa components, lalo na dun sa mga unlabeled na mga supplements. Tapos, sa tumor or cancer kasi, yun nga, yung mga studies naman, specific na mga chemotherapeutic drugs lang yung may effect sa tumor. So, yung mga supplements na mga ganun is not necessarily beneficial directly dun sa tumor. They may provide na benefit po na indirectly, siguro, na may increase yung, there's, in other effect naman, parang may provide yung mga vitamins for kahit pampalakas, mga ganun. Pero not directly dun sa tumor.
Okay, so that's clear, Doc Cal. Thank you po. What about Doc Kim Daniel? Doc, do you have stand regarding this one?
Okay, we should be sure of what these are, as said a while ago, and there is no evidence on the prevention and disease of cancer.
Okay, Doc. So thank you, Doc Kim. Lastly, Dr. Cindy, you know. Okay, so before we formally end po yung ating open forum, portion of this activity may be listened to the final key takeaway message of our resource speakers. So maybe we can start with Dr. Garin po. Okay, so while waiting for Dr. Garin, maybe we can first listen to Dr. Baldonado po. Any key takeaway message po daw?
Hello. Again, salamat po sa pag-imbita sa akin sa talk na to. It's very important for us talaga to give the proper information to our patients, no? Lalo na yung mga sa ating lay people nga, para they would understand ano dapat yung gagawin once they have this kind of diseases. So, uulitin ko po, ang pag-treat po ng sarcoma or any kind of cancer is a multidisciplinary approach. Hindi lang po iisa ang doktor ninyo. Kakailanganin niyo po makausap din yung mga ibang doktor para malaman niyo po yung mga opinion nila, and from there mag-uusap kami mga doctors ninyo para maibigay po namin yung proper na treatment po sa inyo. So maraming salamat po ulit sa pag-imbita sa akin.
Thank you, Doc Arbel, and we are truly grateful also, Doc, for the very clear discussion po ninyo po kanina. Okay, so Dr. Kim Daniel, any final key takeaway message po before we end our open forum? Okay, so that's it. So sa mga nagtatanong po sa ating attendance link po, the evaluation link was already posted dito po sa ating chat box. Okay, so ulitin ko po as a reminder po kanina, para mabigyan po namin kayo ng inyong certificate of participation, may I request individually na magsagot po dito po sa ating evaluation link para mabigyan po kayo ng certificate of participation. And once again, I would, yes, Dr. Cindy. Dr. Cindy is raising her hand. So, ayan. Okay, so na-click lang daw. And on August 16, in celebration of the Asthma Week, Awareness Week, and the Sight Saving Month for August, ang focus po natin is on paano pangalagaan ng ating mga mata at patungkol sa asthma. So, nandito na rin po sa ating chat box yung registration link. Pwede na po kayong magrehistro ng libre. And of course, I would like to promote rin po yung ating BGHMC HCPNCS link Facebook group. Dito po nakapost yung future na usapan po natin, hospital advisories, and announcement aside from the official Facebook page nga po ni BGHMC, the Baguio General Hospital Medical Center Facebook page. Meron rin po kaming BGHMC HCPNCS link na Facebook group. You may want to be a member para makita nyo po yung mga future webinar sessions po namin. And of course, sa mga gustong manood po muli ng mga previews na usapan po natin, meron po kaming YouTube channel, BGHMC Usapang Salun-at. You may want also to visit that and subscribe, like and subscribe. So with that, that officially ends our special edition on sarcoma. For your information, a multidisciplinary team approach. Maraming salamat po. God bless po sa ating lahat and magkita-kita po muli tayo sa August 16. Thank you po.